Dear students, today we will discuss on different granulomatous diseases of the nose. Granuloma is defined as focal area of chronic inflammation produced by circulating monocytes as a part of an immunologic process. You can see here, this is a central necrosis followed by epithelial cells, again followed by lymphocytes and multinucleated giant cells. The basic principle is all these inflammatory factors try to localize the infection in one place. That is the basic mechanism behind granuloma formation. So this acts as the immunologic process. How do you classify nasal granulomas? They can be classified as infective conditions, bacterial conditions like tuberculosis, lupus vulgaris, leprosy, rhinosporidiosis, syphilis, and actinomycosis. Rhinosporidiosis is a common question asked in ENT. Fungal infections like rhinosporidiosis, which is also commonly asked in the exam. Aspergillosis, mucormycosis has most role as COVID-19 infections might lead to mucormycosis, so-called black fungus infection, candidiasis, histoplasmosis, and blastomycosis. Protozoal infections like leishmaniasis and viral infections like AIDS. What are the inflammatory conditions? Sarcoidosis, Wegener's granulomatosis, which is also commonly asked in the final exam, eosinophilic granuloma, Churg-Strauss syndrome or allergic granulomatosis, cholesterol granuloma, and foreign body granulomas. Foreign body granulomas are commonly found in ENT. Neoplastic conditions like T-cell lymphoma and Stewart's granuloma also are the granulomatous conditions of nose. Now let's go to individual conditions. First, to common nasal tuberculosis. Although the incidence of nasal tuberculosis has decreased now, you might get few MCQs asked in the exam. Nasal tuberculosis is associated with primary pulmonary tuberculosis. It affects anterior septum and anterior part of the inferior terminate of nose. There will be nasal obstruction, discharge and pain as with other conditions. The nasal mucosa might be red. There might be nodular thickening. Ulceration might or might not be present. The nasal septum, basically the cartilaginous portion, might be perforated or there might be scarring. Lupus vulgaris is the cutaneous tuberculosis of nose. It is indolent and chronic form of tuberculosis lesions of the skin of nose. It may cause epitheliomatous reaction of the squamous epithelium. So squamous epithelium might grow as epitheliomas. You can see this is the cutaneous form of tuberculosis in the nasal skin. Diascopy is a process of looking through the pressed glass slide against the skin, and it shows typical apple jelly nodule, which will be yellow-brown spots in the nasal skin. This is characteristic of lupus vulgaris. Scarring is more severe. This is the apple jelly. So these features are like apple jelly nodules. This question is commonly asked in MCQ. Apple jelly nodules are seen in. So you should answer they are seen in lupus vulgaris. How to diagnose tuberculosis? Diagnosis of nasal tuberculosis is made by history of previous tuberculosis or active pulmonary tuberculosis. As we told, it is associated with primary pulmonary tuberculosis. Monto test, which is a skin test for delayed hypersensitivity reaction. Monto test is positive in active tuberculosis. Microscopy by Jensen stain will show the tubercular bacilli. Culture of the swab in Lewis-Jensen medium or Middlebrooks medium for 6 to 8 weeks will end the organism. Polymerase chain reaction like gene export have been used nowadays, and histopathological examination of biopsy specimen is the gold standard, which shows casiatic necrosis. This is microscopy showing tubercular bacilli in the high power field. How to treat tuberculosis? It is treated with 2 months course of therapy with isoniazid 5 mg per kg, rifampicin 10 mg per kg, streptomycin 15 mg per kg, and ethambutol 15 mg per kg. Streptomycin is usually used as the second line drug when first line drug do not work, and 6 months therapy of isoniazid and rifampicin is continued. Therefore, we have to treat with 2 HRE plus 6 HR. Sometimes surgical reconstruction is required for nasal defects. Coming to next granulomatous lesion, leprosy, also called as Hansen's disease. The organism causing leprosy is Mycobacterium leprae. I will be discussing the nasal findings of leprosy. As in tuberculosis, the initial stage will be excessive nasal discharge, red swollen mucosa of the nose, crusting and bleeding from the nose. There shall be nodular thickening of mucous membrane, ulcer, perforation of cartilaginous septum. Typical finding in lepromatous leprosy is leonine phases, where we can see nasal destruction, lack of eyebrows and eyelashes, altered pigmentation of the face, and ocular alterations. This is leonine face, lion-like face, with nasal destruction, lack of eyebrows, the facial pigmentation can be seen, there is altered pigmentation of face, and there is ocular alteration. These all make the leonine faces in leprosy. The late sequelae of nose in leprosy is atrophic rhinitis. Because of gross destruction of nose, the nose becomes roomy and there might be atrophic changes. Sudden nose deformity due to destruction of nasal cartilage and septum, destruction of anterior spine, bony destruction, and retraction of columella. Diagnosis is made clinically and by scraping of mucosa and biopsy. Acid-fast bacilli are found in foamy appearing histiocytes, so-called lepra cells. Treatment is with dapsone, rifampicin, and clofazimine. Coming to next granulomatous condition, syphilis. The organism causing syphilis is Treponema pallidum. Pathology behind syphilis is it causes endarteritis of small blood vessels with secondary hypertrophic changes in the endothelium that leads to endarteritis obliterans and luminal obliteration. You can see there is endarteritis obliterans along with luminal obliteration here, and you can see the result of endarteritis in the nose. Coming to different stages, in congenital syphilis, nose is always involved. The infant present with snuffles for 3 weeks to 3 months. Snuffle basically means nasal grunting during breathing. In the early stage of presentation, there will be simple catarrhal rhinitis, which becomes purulent with secondary fissuring and excoriation of the nasal vestibule and the upper lips because of mouth breathing. Nasal obstruction interferes with suckling and nutrition. Intraoral mucous patches and facial skin lesions also are found. You can see here there is nasal discharge and fissuring. There is nasal discharge, fissuring of the oral vestibule is seen here. Here the facial pigmentation seen in congenital syphilis, and you can see oral mucosal patches in the palate. At puberty, there will be gummatous and destructive lesions in the mucous membrane, periosteum, and bone of nasal septum. Ulceration and destruction of the nose leads to secondary atrophic rhinitis and sudden nose deformity. Tertiary syphilis most commonly involves the nose. The pathological lesion in tertiary syphilis is gamma, which might be asked in MCQ, which begins as a subcutaneous nodule, progresses to involve the overlying skin, and breaks down to form punched out destructive ulcer. There is a punched out ulcer here in the nose. Posterior bony septal perforation occurs, and there will be extensive necrosis of nasal and facial tissues, leading to shallow nose deformity. One of the important MCQs in the final exams, syphilis leads to dot perforation, bony septal perforation. Almost all other conditions lead to cartilaginous perforation, but syphilis leads to bony septal perforation. Early symptoms are pain over the nasal bridge, which is worse at night due to neurological conditions. There will be swelling and obstruction, offensive discharge, bleeding, crusting, anosmia, mimic secondary atrophic rhinitis, and there shall be severe scarring of the nose. This is a sudden nose deformity due to bony destruction, and the hard palate has been perforated in syphilis. How to treat syphilis? Syphilis can be treated by parenteral penicillin, which is drug of choice for all stages. Benzathine penicillin G, 2.4 international units IM, single dose is enough for syphilis. Clearance of crusts and regular dosing by copious alkaline doses 1 to 3 times a day, and yellow mercury oxide ointment applied locally as antiseptic measure, and reconstructive surgery for nasal deformities can be performed. Coming to next granulomatous condition, rhinoscleroma, also called as respiratory scleroma, which is commonly asked question in the exam. It is a progressive granulomatous disease commencing in the nose and extending into the nasopharynx, oropharynx, larynx, and sometimes to trachea and the bronchi. So this is called respiratory scleroma. Not only the nose, but nasopharynx, larynx, trachea, bronchi also might be involved. It is caused by Klebsiella rhinoscleromatis, also called as Frisch bacillus. The disease goes through different stages, and they are catarrhal stage, like simple rhinitis, in which condition patient develops foul-smelling purulent rhinorrhea persisting for weeks to months. Then comes atrophic stage, where there will be foul-smelling, large nasal plaques or crust, which simulate atrophic rhinitis. Syphilis, tuberculosis, as well as rhinoscleroma, they all are the causes of secondary atrophic rhinitis. Next comes the granulomatous or proliferative or nodular stage, which is the most active stage of disease, and pathological features are most characteristic. In this condition, the granulomatous nodules enlarge and coalesce, forming the tapered nose deformity. Klebsiella rhinoscleromatis is most commonly isolated during this stage. Next is the cicatrizing stage, that is scarring. Erosions and scarring distort the normal anatomy of the nose, and the nose might become stenosed, so-called Hebra nose deformity. You can see here is the tapered nose, which is in the active stage of disease, that is in the granulomatous or proliferative stage, when the granulomas coalesce together. And the tapered, as you can see, the nose is protruded in the mouth. Hebra nose is the feature of cicatrizing stage of rhinoscleroma, destruction of the nose, simulating the Hebra nose. These questions might be asked in MCQs. Tapered nose is seen in the stage of rhinoscleroma, and Hebra nose is seen in the stage of rhinoscleroma. How to diagnose rhinoscleroma? It is diagnosed by high index of suspicion by coalescent enlarged granulomatous nodules at or near the venous vestibule, diffusion by rat. Microscopy shows the organism in silver impregnation stains, Warthin stari, or gem-size stain. If you culture the infected tissue in granulomatous stage, Klebsiella rhinoscleromatis can be identified in around 98% of the specimens. Complement fixation test also can be performed, and biopsy showing characteristic histological features is the most diagnostic for Klebsiella rhinoscleromatis. Histopathology is the gold standard test for rhinoscleroma. Nucleic cells are pathognomonic cells for diagnosis of rhinoscleroma, and they are scattered large foam cells with a central nucleus and vacuolated cytoplasm which contain Klebsiella bacilli. These are the cells. You can see this is central nucleus and vacuolated cytoplasm. There are many cells, and they are basically transformed macrophages which have ingested the bacillus. So this is the pathognomonic feature. Russell bodies are eosinophilic inclusions in plasma cells having a eccentric nucleus and deep eosin staining cytoplasm. So they are less diagnostic for rhinoscleroma, and mucoelic cells are the most important cells as diagnostic of rhinoscleroma. This might be asked in the exam. How to treat rhinoscleroma? High dose of bactericidal antibiotics to be used for a minimum of 4 to 6 weeks, which will be continuous until 2 consecutive cultures from biopsy material are proven negative, because the organism stays in the mucosa and the skin. Streptomycin in a dose of 1 gram per day and tetracycline in a dose of 2 gram per day are commonly used. Rifampicin, sulfamethoxazole and trimethoprim combination, and ciprofloxacin also has been commonly used. Local application of 2% acryclabin for 8 weeks has also been used in rhinoscleroma. Irradiation therapy 30 to 35 degrees over 3 weeks can be used. Surgical debridement for nasal ulcers and nodules, and reconstructive surgery for nasal deformity can be performed. Coming to next important topic for today, rhinosporidiosis. It is usually asked in the exam. It is chronic granulomatous infection that affects the nasal mucosa in 70% individuals, ocular conjunctiva, and other mucous membranes. The organism is Rhinosporidium severi. It is still unclear if it is a fungus or it's a protozoa. It is commonly found in eastern Tarai belt of Nepal, like Janakpur and Rajbiras, which is contracted by immersion in contaminated water of wounds containing animal dungs. So they are the carriers. Clinical features are insidious onset of painless and gradual nasal obstruction. The findings in the nose are large sessile or penetrated lesions, which are leafy, papillomatous or proliferative lesions, which are studded with white dots. They are the sporangia of rhinosporidiosis. The color might be pink, red or purple, and the lesion is vascular and bleeds on touch. When a person or patient from Tarai region of Nepal comes to you with a history of bleeding from unilateral or bilateral nostrils, and if you see large proliferative lesions in the nose which are studded with white dots, you have to think of rhinosporidiosis. It's also a commonly asked question in the final exams. You can see here this is the mass in the nose with white dots. There are white dots. On endoscopy you can see pink mass with white dots, sporangia of the organism. Sporangia burst to release the endospore. This is the life cycle of Rhinosporidium severi. As we told, histopathology is the diagnostic feature. You can see pseudoepitheliomatous squamous cell metaplasia, which overlies numerous multi-sized microscopic globular cysts called sporangia, with thick wall and an operculum. The large sporangia are filled with endospores, and granulomatous reaction of fibrous tissue, neutrophils, plasma cells and lymphocytes is common. So we told granulomas are basically they are the immunogenic factors. They try to localize the infection in one site. How to treat rhinosporidiosis? Complete surgical excision with cauterization of the base is one of the key treatment for rhinosporidiosis. Otherwise, the organism, as you know, again, it is staying in the nose and it might recover after surgery. Dapsone is given as 100 mg per day for 6 months. The role of dapsone is to arrest maturation of sporangia and accentuate granulomatous response with fibrosis. So, when there is fibrosis, there is less chance that the organism might grow, or epitheliomatous reaction will not happen when there is increased fibrosis. Amphotericin B can be used supposing that the organism is fungus, but it is not sure if the organism is fungus and protozoa till now. So most common management is surgical only, that is complete removal with cauterization of the base. Medical treatment has not been found to be much effective in rhinosporidiosis. Coming to next condition, Wegener's granulomatosis or rhinogenic granulomatosis or systemic vasculitis. This is autoimmune multisystem disorder which is characterized by a triad of granulomatous inflammation of the upper and lower respiratory tract, necrotizing vasculitis affecting small to medium-sized blood vessels, and necrotizing glomerulonephritis. It is commonly found in the 4th to 5th decade of life, and males are more commonly affected than females. The etiology is inflammatory, hypersensitivity reactions with an immune response. Again, all the granulomas, they are basically found to be immunogenic, and there will be deposition of immune complex which leads to vasculitis of small to medium sized blood vessels. Wegener's granulomatosis can be divided into different types. They are type 1 is limited to nose, type 2 more systemic involvement, and type 3 is widely disseminated disease. You can see the different organs involved by Wegener's granulomatosis here. Clinical features: the patient develops progressive malaise, pyrexia, weight loss. Nose and the sinuses are involved in around 80% of individuals with mucosal edema, nasal obstruction, and sinusitis. There will be crusting of the nasal cavity. There might be septal perforation, or there might be saddle nose. You can see there is palatal ulceration here and palatal perforation. Oral cavity and pharyngeal findings are hyperplastic granular lesion of gingiva, ulcerative stomatitis, and pharyngitis. Ocular symptoms occur in around 20% of individuals with conjunctivitis, episcleritis, corneal ulceration, optic neuritis, retinal artery occlusion, and proptosis. Pulmonary symptoms like cough, hemoptysis, pleuritic chest pain are also common. Systemic vasculitis might affect the lungs. Renal symptoms occur in 30 to 90% of individuals as hematuria or oliguria, that is, involvement of kidney by glomerulonephritis. Autological symptoms, recurrent OME or AOM are also common. Laryngeal and tracheal symptoms like subglottic and upper tracheal stenosis might be found, but they are unusual. Central nervous system symptoms are also found in 10 to 15% of the individuals. Other features like polymyalgia, polyarthritis, and ulceration of skin in distal arms and legs also can be found in the patients. How to investigate Wegener's granulomatosis? Increase erythrocyte sedimentation rate, which is very important. It's raised more than 45, and this is one of the prognostic criteria. If the ESR decreases, then we think that the disease is controlled. C-reactive protein will be raised in C-ANCA is the anti-neutrophil cytoplasmic antibody is positive in 95% of individuals, and even in 60% of localized disease will show C-ANCA positive. Serum angiotensin converting enzyme SAC is raised in blood urea. Serum creatinine may be raised because patient will be having glomerulonephritis and sometimes kidney failure. Urine RE or ME will show cast or protein. Chest X-ray will show nodular lesions with cavitation. Tissue biopsy showing typical histological features will be diagnostic for Wegener's granulomatosis. Let's come to CT or MRI scan. In CT scan, we can see non-specific mucosal thickening on nose or PNS in 86% of individuals. Therefore, it is not that much diagnostic. There will be evidence of bone destruction in 75% of individuals. New bone formation in walls of sinuses can be seen in 50% of the individuals, and orbit is affected in 30%. MRI shows fat signal from sclerotic sinus wall. So sinus wall will be thickened and sclerotic. This is a chest CT scan. You can see the cavitation is there. Here is also cavitation, and you can see the nodular thickening. Okay, so nodular thickening plus cavitation will be suggestive of Wisner's granulomatosis along with nasal findings and biopsy findings. What are the histological features? They are fibrinoid vascular necrosis. Granulomas are epithelial type and they are large, irregular and lined with histiocytes. They may show fibrinoid necrosis or be non-necrotic. And we can see multinucleated giant cells and eosinophils as a part of granuloma. What are different criteria for diagnosis of Wisner's granulomatosis? They are nasal or oral inflammation, leading to painful or painless oral ulcers or purulent or bloody nasal discharge, abnormal chest X-ray with presence of nodules, fixed infiltrates or cavities, urinary sediment like microhematuria over 5 abscesses per high power field or red cell cast in urine sediment, and granulomatous inflammation on biopsy. The histology showing granulomatous inflammation within wall of the artery or in peri or extravascular area, which is very commonly found in Wisner's granulomatosis. Any two or more of the four criteria suggest Wisner's granulomatosis. How to treat Wisner's granulomatosis? Prednisone and cyclophosphamide, the key treatment for Wisner's granulomatosis. The gold standard therapy is prednisone 1 mg per kg per day plus cyclophosphamide 2 mg per kg per day for 1 month. Then prednisone tapered to alternate days for 2 more months and stopped after achievement of complete response. So you have to see for CANCA, you have to see for ESR and patient symptoms. Once complete response is obtained, then you have to stop prednisone. Cyclophosphamide continued for 6 months to 1 year and is tapered over a few months. There are many side effects of cyclophosphamide like cystitis, bladder cancer, lymphoma, AIDS. Azathioprine as a dose of 2 to 3 mg per kg per day can be used to avoid the side effects of cyclophosphamide because it causes less side effects than cyclophosphamide. Trimethoprim sulfamethoxazole combination can be used to avoid pneumocystic kidney pneumonia, which is very commonly found in patients with Wisner's granulomatosis as there are nodules, cavities in the chest. Methotrexate, cyclosporin, rituximab are commonly used new medicines for Wisner's granulomatosis. As we have already told, prognosis of Wisner's granulomatosis will be good if we use combination medicines, and if untreated, most of the patients die within 6 months. Therefore, early identification and early treatment modalities is important for cure of Wisner's granulomatosis. Stay safe. Have a good day. Thank you.